So this is a neurotraumatic and neurovascular lineage as in how it happens. So primary disease, either it is sensory motor neuropathy or autonomic. Either ways, you have systemic failure, you won't feel it. You get a high risk for trauma or instability, then you get it. So in acute inflammation, and this cycle continues. So clinical features are, see, acute and chronic stage. Always remember it will be hot, swollen, erythematous foot. Bony crepitus would be there because of osteomyelitis, which sets in the metatarsal area, metatarsal bone. Pain is conspicuous by its mildness because of the diabetes or absence. Patient may recall minor trauma weeks or days ahead, and usually in the midfoot. So you need to have an eye for midfoot. Pay attention there. Chronic stages, patient presents with various deformities, including flat foot, rocker bottom foot. Usually vascularity of the foot will be good and pulses may be pounding, as I mentioned earlier. So you see, this is the metatarsal area. You will have the fracture, which will lead to the swelling of the foot, which can be seen on the left side, and it's a slight tilt, so that is slight deformity. So erosion, it's quietly evident on tarsal metatarsal area. Peripheral arterial disease, it's a macrovascular complication of diabetes due to atherosclerotic occlusion. So delivery of oxygen and nutrients is decreased. Patient have an intermittent claudication history, and maybe the claudication may be absent if there is concomitant sensory neuropathy. So see, these two coexist. So you will have to have an eye for loss of hair, atrophy of skin, nails, shiny thing, poor relief, foot injuries, ulceration, and lead to necrosis and gangrene. So these are ischemic foot. So now this is a different aspect where you have less blood flow because of atherosclerotic occlusion. So this is the black foot or the black toe you could see is the gangrene, which needs to be ultimately amputated. Mostly in a diabetic OPD, this is very frequently seen. And in the last but one third image, you could see that it's already peeling away. So it's completely gangrenous. So this is the differentiating factors. If you see the two neuropathic and ischemic foot. So neuropathic is pressure points on bony prominence. This is usually dorsum on tip of the foot. Pain usually nocturnal. Here they have present initially, but later on maybe rest pain. Blisters are common. Here is rare. Deformity, it's common. Prognosis heals faster because of the blood supply. Here there is no blood supply unless heals later, or you may have to be amputated. The pulses are absent, temperature of foot cold and warm that you can see. Treatment is usually neuropathic pressure distribution and local things. And here you need to actually go for revascularization for and also recanalization also of the lower arterial system. In India, majority of foot ulcers are neuropathic in origin. So comparison of features of neuropathy and ischemic ulcers. Ischemic ulcers. Hello. Right. So comparison of features of neuropathic. If you could see, actually it is deep down there, and you can see the ulcers, their margins, circumferential stuff. And here in the third picture, it is ischemic. So you could see the black part, and it's on the edge. There on the pressure points, the neuropathic, and these are on the edge. So precipitating factors for foot ulcers. Barefoot or walking predisposes to mechanical and thermal injury. Shoe bite from ill-fitting footwear, home surgery for corns and calluses, improper cutting of nails, and insect and rodent bites.